Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a young patient who presents with visual symptoms, a cerebellar lesion, renal cysts, and a family history of early renal cancer. The key question is not just what is the tumor? The key question is this part of an inherited tumor predisposition syndrome? In MRCP, when you see multiple vascular tumors, renal cell carcinoma, pancreatic cysts, and pheochromocytoma, think of von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome, or VHL, is an autosomal dominant tumor predisposition syndrome caused by a germline mutation in the VHL gene. This leads to loss of function of pVHL, which is a tumor suppressor protein. So the central idea is simple. The tumor suppressor brake is lost, and multiple cysts and tumors can form in different organs. Now let us understand the mechanism, because the mechanism explains almost everything. The VHL gene is on chromosome 3p25. Normally, the pVHL protein helps degrade HEF-alpha, especially HEF-1-alpha and HEF-2-alpha. HEF stands for hypoxia-inducible factor. Under normal oxygen conditions, HEF-alpha should be broken down, but when pVHL is lost, HEF-alpha accumulates even when oxygen is normal. So the arrow flow is, VHL mutation leads to loss of pVHL, which leads to increased HIF-alpha, which then increases VEGF, PDGF, and EPO. VEGF and PDGF drive angiogenesis and tumor growth, while EPO can contribute to erythrocytosis in some cases. This is why VHL tumors are often highly vascular, and why hemangioblastomas and clear cell renal cell carcinoma are such classic associations. Inheritance is autosomal dominant, with high penetrance. That means one pathogenic copy can be enough to predispose to disease, and each child of an affected individual has a 50% chance of inheriting the variant. MRCP trap. Do not think of VHL as a single tumor condition. Think of it as a lifelong, multi-organ tumor surveillance condition. Clinically, we can group the features into a few major boxes: brain and retina, kidney and adrenal region, pancreas, ear, and reproductive tract cystadenomas. First, brain and retina. VHL is classically associated with central nervous system and retinal hemangioblastomas. These are vascular tumors. In the cerebellum or spinal cord, they may cause headache, ataxia, vomiting, or focal neurological signs because of mass effect, oedema, or obstruction of cerebrospinal fluid flow. In the retina, hemangioblastomas can cause visual loss. The key clue is the combination of a vascular CNS lesion with retinal lesions or renal cancer in a young patient. Second, the kidney. Clear cell renal cell carcinoma is one of the most important manifestations of VHL, and it is a major driver of mortality. Patients may also develop multiple renal cysts. In exams, bilateral, multifocal, or early-onset clear cell RCC should make you think about an inherited syndrome, and VHL is one of the key diagnoses. Third, pheochromocytoma and paraganglioma. These tumors can produce catecholamines, leading to episodic hypertension, palpitations, sweating, tremor, and headaches. MRCP trap. If a patient with VHL needs surgery and has a pheochromocytoma, you must not miss alpha blockade before surgery. Giving beta blockade first can worsen hypertension because of unopposed alpha stimulation. Fourth, the pancreas. VHL can cause pancreatic cysts, serous cystadenomas, and pancreatic neuroendocrine tumors. The pancreatic lesions are often detected on surveillance imaging, and the clinical importance depends on growth, size, symptoms, and malignant potential. Fifth, the ear. Endolymphatic sac tumors can cause hearing loss, tinnitus, and vertigo. This is a useful exam association because it links an inherited cancer syndrome with audiological symptoms. And finally, the reproductive tract. Males may develop epididymal cystadenomas, and females may develop broad ligament cystadenomas. These are not usually the main mortality issue, but they are useful diagnostic clues when seen alongside the classic VHL tumor pattern. Now look at the memory picture. This image is designed to help you remember the different tumors associated with one VHL or one von Hippel-Lindau syndrome. The hippo represents Hippel-Lindau. The hippo is causing chaos because the tumor suppressor is not working. In other words, pVHL is lost and the normal brake on HIF-driven tumor biology has failed. The frightened person has hair standing up, which can remind you of central nervous system involvement, especially cerebellar or spinal hemangioblastomas, causing headache, ataxia, and neurological symptoms. His eyes are prominent, which should remind you of retinal hemangioblastomas. Be careful here. In VHL, the retinal tumor is a retinal hemangioblastoma, not retinoblastoma. The person standing with his hands over the back and flank area reminds you of renal lesions, especially clear cell renal cell carcinoma and renal cysts. Because the hands are near the upper back and adrenal region, this can also remind you of suprarenal tumors, particularly pheochromocytoma. The pregnant lady helps you remember reproductive tract cystadenomas, including broad ligament cystadenomas in females, and by association, epididymal cystadenomas in males. The hippo's mouth is close to the pancreas region, helping you remember pancreatic cysts, serous cystadenomas, and pancreatic neuroendocrine tumors. The water flowing around the hippo helps you remember endolymphatic sac tumors, which cause hearing loss, tinnitus, and vertigo. So the whole picture tells one story. One unsuppressed hippo, meaning loss of the VHL tumor suppressor, leads to multiple tumors across the brain, retina, kidney, adrenal region, pancreas, ear, and reproductive tract. Now, how do we diagnose it? Suspect VHL when there are characteristic tumors, especially when lesions are early onset, bilateral, multifocal, or there is a positive family history. The diagnosis is confirmed with germline VHL genetic testing. Once a pathogenic variant is identified, relatives should be offered genetic counseling and testing, because this is an autosomal dominant condition and surveillance can prevent major morbidity. Management is lifelong and proactive. This is not a one-time treatment disease. It is a surveillance disease. Patients need regular screening for CNS and retinal hemangioblastomas, abdominal imaging for renal and pancreatic lesions, biochemical testing with plasma or urinary metanephrines for pheochromocytoma, and audiology assessment for endolymphatic sac tumors. Treatment is lesion-directed. Symptomatic or growing hemangioblastomas may need surgical resection. Renal cell carcinoma is managed with nephron-sparing approaches where possible, such as partial nephrectomy or ablation, often when the lesion approaches 3 centimeters. This threshold is important because the aim is to reduce metastatic risk while preserving renal function, as these patients may develop multiple renal lesions over their lifetime. For pheochromocytoma, the key step is alpha blockade before surgery. Adrenal sparing surgery may be considered where feasible, because bilateral or recurrent adrenal disease can lead to long-term steroid dependence if both adrenal glands are removed. A newer targeted option is belzutifan, a HEF2 alpha inhibitor. This directly targets the HEF-driven biology of VHL. It may be used in selected patients with VHL-associated renal cell carcinoma, CNS hemangioblastomas, or pancreatic neuroendocrine tumors that do not require immediate surgery. The exam concept is elegant. VHL loss increases HIF activity, and belzutifan inhibits HIF2 alpha. If you remember one thing, remember this. VHL is an autosomal dominant loss of a tumor suppressor on chromosome 3p25, causing increased HIF activity in multiple vascular tumors, especially CNS and retinal hemangioblastomas, clear cell renal cell carcinoma, pheochromocytoma, pancreatic lesions, and endolymphatic sac tumors. Quick recall. A young patient has a cerebellar hemangioblastoma, retinal hemangioblastoma, pancreatic cysts, and bilateral clear cell renal cell carcinoma. What syndrome should you think of, and what is the key molecular mechanism? The answer is von Hippel-Lindau syndrome. The mechanism is germline VHL mutation causing loss of pVHL, failure to degrade F-alpha, increased VEGF, PDGF, and EPO, and therefore angiogenesis with cyst and tumor formation. Quick recall. A patient with VHL has episodic hypertension, sweating, palpitations, and is being prepared for surgery. What tumor must you look for? And what treatment step must not be missed? The answer is pheochromocytoma. You must check metanephrines and give alpha blockade before surgery before considering beta blockade. Do subscribe to the channel for further videos.